Hopefully, in the next 5 years, we're going to really see that shift. And like we see in other types of lymphoid malignancies like CLL or things like that, where we see really the end of chemotherapy. I think we're hopefully going to see that in follicular lymphoma in the years to come.
That's Dr. Ben Heyman with City of Hope San Diego. He's describing a shift he's seen toward novel immunotherapy approaches. You'll hear more from him later in the show. Welcome back to the award-winning Cancer Buzz. I'm your host, Summer Johnson. Relapsed and refractory follicular lymphoma is challenging to treat and requires a balance of efficacy and quality of life. Today on the show, we're talking about how to navigate potential treatment pathways for patients living with this disease and tools to improve the delivery of care services. Designing the right treatment plan means teams have to be dedicated to individualized high-quality care and know how to ask the right questions.
What is the status of their disease? Are they having symptoms related to their disease? Are there indications for therapy? That's kind of always the initial kind of assessment, when you see patients. And so that doesn't change when they have relapsed disease. And so it's always really important, because for patients who don't meet indications for therapy in the relapse setting, then their therapy still isn't warranted, even though the disease has come back. So I think that's always really the most important question whenever you take care of a patient with indolent lymphoma is therapy warranted?
Dr. Ben Heyman is a hematologist and clinical associate professor with City of Hope in San Diego, California. Over the years, he's seen the number of available treatments grow significantly, giving patients more control over their plan of action.
There are lots of different therapies available for patients with relapsed follicular lymphoma nowadays. And the timing of the relapse, what therapies they initially had, how many different therapies they have, all kind of come into play. But there are lots of options available, which is really great for patients. And so you get to have a good conversation with patients about what do they value? Do they value the length of the remission? Do they value potential balance of side effects versus efficacy? Do they value potentially being in the hospital versus getting all their treatment as an outpatient? All these things are conversations that you get to have with patients when you're deciding when they need therapy. What is the best choice for them?
He says that in a relapsed setting, many patients have already received chemoimmunotherapy as their first line of treatment and are exploring experimental alternatives as the next step.
I'm always thinking, can we potentially think about doing clinical trials? We know that there are new therapies, immunotherapies, as well as targeted therapies that really do hold promise for patients. Potentially have less toxicity and can have long-term efficacy. So I do think if those are available to patients, those are options that I would encourage patients to think about.
When we asked Heyman about caring for patients who have been through multiple lines of treatment and continue to relapse, he said there are several treatments that have become available in recent years.
When we think about in later lines of therapy, we have newer immunotherapy approaches. These are medications called T-cell engagers. These are antibodies which work specifically by essentially bringing our body's immune system in together with the cancer cells and essentially help them overcome ways that the cancer cells are able to avoid them. And these are medications that have been approved, one called mosunetuzumab, another one called epcoritamab. They work quite well in treating patients' lymphomas. Another type of immunotherapy called CAR T-cell therapy, which can also really, we know, can produce really durable responses for patients, has high efficacy. All these are great options.
He says one of the most important considerations when selecting a course of treatment is how aggressive the lymphoma is in response to the patient's first line of chemotherapy.
For patients who are really high risk for their follicular lymphoma, meaning that they've had a very early recurrence from their frontline chemoimmunotherapy, typically we define that as within 2 years, but I think of really the highest risk is within 1 year of recurrence. Those patients have really poor survival, or those patients who've been refractory to rituximab or refractory to an alkylator such as bendamustine. Then I might think about, do we need to think about how aggressive do we need to be in their therapy? So for those patients who are really high risk, then I might think about, what is the risk reward here? What has the highest efficacy versus, safety?
When it comes to early recurrence of relapsed follicular lymphoma, Laurie Adami is familiar. Adami is now a patient advocate with the Leukemia and Lymphoma Society, now Blood Cancer United, and works to help patients with cancer navigate the challenges that come with a new diagnosis. But she was once on the other side of the cancer care system.
I was diagnosed with stage 4 follicular non-Hodgkin lymphoma. So in 2006, 19 years ago. At the time, and I had very, very bulky disease, so I was not a follicular patient who could watch and wait for a while because I was severely symptomatic. I had a tumor. It was described as the size of a small watermelon in my mesentery and extensive disease everywhere.
After 6 cycles of treatment, Adami was told she was in remission, but unfortunately, that wasn't the end of her cancer journey.
Dr. Heyman just talked about patients that relapse in less than a year. I relapsed in way less than a year. At my first follow-up scan, 3 months later, it was already back. So, of course, at that point, they rebiopsied me and, I was still had follicular. And we were able to watch it for over a year. I was still working, and I would go in for scans every 3 to 6 months. And then I got to the point where I had to treat. And at that point, there were some trials, but nothing looked really promising. And there was like a new radioimmunotherapy treatment that was in trial. There was new chemo that was in trial. But I was being pushed to do an auto stem cell transplant, which is with my own cells.
But Adami knew the recommended course of treatment wasn't the right fit for her or her family.
I started researching the outcomes for autologous stem cell transplant. And I discovered that I had very low odds of success with auto transplant because basically anybody who relapsed that quickly after chemo is going to also relapse very quickly after subsequent chemo and stem cell transplant. And I would have to be in the hospital for a month, which my little kid was in kindergarten at that point. I couldn't do.
She went on to participate in a clinical trial, followed by another line of treatment with a recently approved chemotherapy. When both of those seemed to fail, Adami moved on to radioimmunotherapy. Initially, the treatment showed promise, but eventually Adami's follicular lymphoma became refractory and began to grow again.
So I had relapsed after my 4th treatment. So now I'm out, I'm now in 2011. And the only thing left for me at this point is an allogeneic stem cell transplant, which is where you get a donor's immune system. And neither of my siblings were matches. So I had to go into the unrelated donor banks, which increased the risk of the transplant because then very likely I would end up with what's called graft versus host disease, where my new immune system from my donor would begin to reject my organs. And it can happen to your skin. Your skin is the largest organ in your body. It can happen to your kidneys, to your liver. I met a woman who was blind because her GVHD attacked her optic nerves. So she lost her vision. And to add on to that, the risk of dying in the hospital, which is not insignificant, because once they take your immune system down to get ready to infuse your donor's immune system, and before you can get it to graft, you're at risk of infection. And I've known patients that got pneumonia during this time and died from the pneumonia once they had that lost immunity.
Adami was determined to find a better way forward and decided to look for new clinical trials that she could participate in. She emailed cancer researchers all over the world until one day she got a call back. It was a researcher from UCLA, which just happened to be in the city where Adami lived.
And he said, Miss Adami, he said, I got your email. I need you to come in today. I have a phase 1 clinical trial of a PI3 kinase inhibitor, which is a small molecule drug like the verinostat which was on that I was on before. Only this one targeted a different enzyme that lived on my cancer. He said it's a phase 1 trial, and I have 19 patients already enrolled. very heavily treated like you, doing very well, and I only have one slot left. So if you don't come in today, one of my associates is going to give this spot away. And it was so bizarre because I had to pick my son up at school that day. He was now in 5th grade. And then I was going to work at a fundraiser for the Lymphoma Research Foundation that one of my cancer friends was hosting in the clubhouse at her community. And I said, I got to go pick up my son at school and I got to go to this fundraiser. And the doctor said, Laurie, he said, are you going to the LRF fundraiser by any chance? Because I'm going to be there. I'll bring the paperwork. We can sit and talk about it. You can sign. Is that a bizarre coincidence?
Adami became patient 20, and the treatment successfully kept her disease stable for 5.5 years. And although the cancer eventually stopped responding to the medication, it was incredibly successful in managing her condition and buying her time. In those 5.5 years, several new therapies had been approved and several more were on their way. Adami began her 6th line of treatment, which gave her just enough time to get enrolled in her final line of treatment, a new CAR T-cell clinical trial.
So I went in really, really sick. And by day, I think 3, after my CAR T infusion, my kidney enzymes were normal. That's how fast it worked. And on day 30, I was wheeled into the PET CT machine at UCLA. And for the first time in 12 years, from 2006 to 2018, the oncologist came in that afternoon. Actually, my oncologist called me and said, Laurie, you're in complete remission. And I didn't believe it.
Adami has now been in remission for 7 years. We spoke to Heyman about the importance of clinical trials in the treatment of relapse and refractory follicular lymphoma, and he shared that while they may not be the perfect choice for all patients, often they offer the potential for better treatment with less long-term side effects and more promising efficacy.
The medications you receive in clinical trials may not be the standard of care today, but it may be the standard of care in 5 years from now. And so clinical trials, I think thinking about early on for patients, referring for clinical trials is a really good idea because one, even if patients aren't available, maybe there isn't a clinical trial available to them at that point in their disease, it kind of gets them in the door, so that maybe 2-3 years from now, when their disease comes back or in their different situation, that they have that relationship, then at that point they can come back to think about those clinical trials. But you never know what's available to them, right?
As cancer diagnoses and treatment options continue to grow, Heyman points out that it's important for providers to learn about new therapies that are becoming available. One way to keep track is by using the Effective Practice Guide developed by ACCC, Blood Cancer United, and the Lymphoma Research Foundation. Heyman says the resource has been a help for him in both clinical and patient-centered settings.
It's hard to stay up to date on all the data that's available out there for anybody. I mean, I think as someone who focuses specifically on patients with lymphoma, lymphoid malignancies, lymphoma, and CLL, I know I try my best to stay up to date on a few diseases, some diseases, right? And so that's kind of my domain. But for people who are in the, for general oncologists who are having to stay focused on lots of things, lots of different diseases, or all the whole breadth of hematology oncology, that can be that's a monumental task that I'm always really impressed and by my colleagues who are able to do that. It's really difficult. So I think having something that's just readily available, that you can reference, you can take it with you into the clinic or with your patient visit and just have it available and kind of quickly reference it to it. That's kind of something easy to have, readily available to you.
Adami's recommendation to providers who are looking for ways to establish a better continuum of care is to connect them with nonprofit organizations that are equipped to provide the support they need.
There are nonprofits like the Leukemia and Lymphoma Society, which is now being renamed Blood Cancer United, and the Lymphoma Research Foundation, and the CLL Society, and the Multiple Myeloma. They're all these nonprofits that can help a patient. And these doctors need to tell the patient to contact, because these patient advocacy organizations have patients that can talk to you. They know what you're talking about. They're on the road ahead of you. And that's what I do as a patient advocate.
Moving forward, Heyman is optimistic about the progress that will continue to be made to benefit all patients with follicular lymphoma.
We're seeing lots of these more novel therapies that have the potential to give us kind of long-term efficacy, but at the same time potentially minimize those long-term side effects of chemotherapy that we worry about. Things like potential for secondary malignancies and things like that we know that really just have harmed patients in the past. So I think that has been something that we're I think is really promising and exciting for us in the field. And so I think hopefully, in the next 5 years, we're going to really see that shift. And like we've seen in other types of lymphoid malignancies like CLL or things like that, where we've seen really the end of chemotherapy. I think we're hopefully going to see that in follicular lymphoma in the years to come.
Thank you to our guests today. For resources on managing relapsed and refractory follicular lymphoma, you can check out the show notes. Until next time, for the Cancer Buzz team, this is Summer Johnson.